All right, that's fine. It's just in case. Yes, that's the backup. Oh, we're live streaming already? Yes. I think Janelle can edit it later.
Yeah, after evening, yeah, I can remove this part.
Yeah. Yeah, quite a few persons logging in to learn about cardiac testing. I think it may be the speaker that is the main attraction and not the topic. So we'll give another 2 minutes and then we can kind of get started with our usual background. Mm. All right. Okay. All right. I think we can begin. Again, thanks everyone for joining us this evening for our live talk. This is one of the efforts that we make to try and reach out to a number of our participants who have taken part in this cohort study. And usually once a month we meet to discuss different topics. This is Heart Month, and we've been talking about heart disease since last month. Tonight we have a special guest, Professor Ferguson, who I'll introduce in a few minutes. But just to sort of set the stage, we usually just give a little introduction to the live project, just in case there's anyone here who's hearing about the project for the first time or is interested in learning a little bit more about what this project is all about. And you're actually looking at the person who helped develop the acronym LIFE, Professor Ferguson, Living in Full Health Project. Is much nicer than the name we originally had for this study. All right, so what's this all about? Well, one of the things we recognize is happening in Jamaica is that we have a lot of chronic diseases, and the chronic diseases are probably driven by a number of factors, including things like obesity. So in Jamaica, when we look at our breakdown of the population by age and sex, we find that obesity is one of the big challenges that we have, especially among women, where the prevalence or the number of persons who have obesity increases steadily as people get older, with about over 50% of women who are in their 30s and 40s being in the obese category. It's a lot higher in women, as I said, than men. But one of the things is that obesity sets the stage for a number of other chronic illnesses, such as hypertension and diabetes. And the pattern of obesity is what we see reflected in the pattern of some of the other chronic diseases like diabetes, for instance. Diabetes is very strongly associated with it. And what you can see here, just like you saw with a lot more women being obese than men, the number of women who have diabetes is also higher compared to men. And of course, again, just like obesity, as age increased, so did obesity. The same thing we're seeing here with age, diabetes, the number of people with diabetes increases steadily. So that by the time you are in persons who are living over 75 years old, nearly 40% of them will have diabetes. Hypertension is a lot more common. It again increases with age, so it's higher rates in older persons. And unlike diabetes and hypertension, differences that you're seeing in men and women are not that marked. But one of the things to note is that by the time people are in their 50s, we're looking at about 3/4 of Jamaicans who have high blood pressure. And so what this sets the stage for is a lot of chronic illnesses. When we look at leading causes of death in persons over 5 years, both for men and women, the chronic diseases are in the top 5 or 10. So for men, apart from accidents and violence, stroke, diabetes, heart disease, and cancer are the leading causes of death. In women, diabetes, stroke, high blood pressure related heart disease, ischemic heart disease, and breast cancer in the case of women are leading causes of death. So this is one of the reasons why we're interested in doing the life study, because we're trying to understand why is it that such a large proportion of Jamaicans are suffering from chronic diseases. And the life study is a little different from what most people are accustomed to when they're asked to participate in studies, because this is a cohort study. So a cohort is a follow-up study where we look at people even before they may develop a particular illness and follow them over time to see what are the factors that may increase their risk of developing these conditions or may protect them from developing these conditions. And one advantage of these cohort studies or follow-up studies is that we can look at multiple conditions. So what you saw with the data is that we have a number of health issues, not just the obesity, but the diabetes, the hypertension, the cancers, and we can take a group of persons and follow over time to see what is it that is causing some people to develop any one of these major conditions. And because of this follow-up, it gives us really the best evidence that the things that we were seeing before the disease started are likely to be things that are resulting in the disease when we see it occurring. So the life study is island-wide. We're going back to communities that were part of the last Jamaica Health and Lifestyle Survey that was done in 2016-17. And in each of these communities, we start by looking for participants who are part of this survey. And then in addition to those persons, we're going house to house and inviting other persons who are living in these communities to also participate in the study. What does it involve? Well, questionnaires which people are accustomed to, and this one is very detailed, and the reason why it's detailed is because there are so many risk factors for non-communicable diseases like cancer, heart disease, and diabetes that we have to ask about various aspects of life, not just your family history, because we know genetic factors may be important. We ask about your habits in terms of exercise, smoking, eating, sleep, etc. We also ask about your health history, and that is very important in helping us to understand what's going on. In addition to the questionnaires, participants are asked to give specimens, and these are blood, urine, saliva, and nails and hair. We haven't been doing much saliva because of COVID, but these are specimens that we can go back to, and we use some of them to help to identify problems that people may have, like if they're anemic or have diabetes or cholesterol issues. But over time, we can go back and begin to understand if there are new things that we never thought about measuring that may also be important in helping us to identify people who are at risk. And of course, because of follow-up study, we are going to come back to you, and we're interested in you telling us whether you develop any of the disease conditions we have been interested in studying or understanding. So whether you develop diabetes, any form of heart disease, or cancer. And so this is an important part of the project. And so we want people who are able to commit. So what are the benefits that you might get? Well, I have been looking at the reports. I see a lot of people whose blood sugars are not controlled, who have high blood pressure, and they didn't realize that it wasn't there. Those who have elevated cholesterol levels because they haven't been checked, or anemic. So I think this provides you with an opportunity to understand some of your own health issues. And then some of the questions we ask may help you to recognize that some of the things you didn't think were important may actually be playing a role in your overall health, how you sleep, your activity, the environment in which you live in, etc. The study will hopefully help us to pick up new approaches to identifying things like cancer or diabetes or heart disease, because these specimens will be there and can be used to check for new tests, and it may help maybe you in your own lifestyle time, or other family members who may be at risk for these conditions, so we can diagnose them early and prevent complications. And of course, at a higher level, it provides information that's used by governments to help prevent and treat chronic diseases, which would in turn benefit you if you have a chronic disease or your family member. The investigative team is from Jamaica, the Caribbean Institute for Health Research primarily, as well as the Fox Chase Cancer Center. The investigator there is a Jamaican, Professor Camille Reagan, and we're also working with another Caribbean investigator, Dr. Kimlin Ashing, who is based at the City of Hope Cancer Research Center, and that is in Los Angeles. There are other members of the team. For those who are participants, you'll run into them either when they're collecting data, meeting with you, and so on, or nurses, research assistants, phlebotomists, and the list continues to grow as the project expands. And so this is our final slide, just showing you our tree. This is the tree that you see in the image there for the LIFE project. It's from the African baobab tree. It's one of these trees that is very common in Africa. It has very deep roots, so it goes down, and very often it provides shelter and water for animals, even when things are very, very difficult or challenging. And so we think that this is an apt symbol for the project and the work that we want to do. So with those introductory remarks, I'm going to stop sharing and put our guest speaker on alert. He's already on alert. He has made special plans in case he loses his internet before, before we finish. But I'm very pleased that we have with us Professor Trevor Ferguson, who is well, one of the investigators on the project, but he has many other hats. He's a professor of epidemiology, and it's not just a study of skin, that's a study of disease patterns, and also internal medicine. I'll tell you a little bit more about internal medicine. And he's also the director of the Epidemiology Research Unit in the Caribbean Institute for Health Research. So Professor Ferguson is a graduate of St. Jago High School, and he'll tell you that if you want to look for him on Schools Challenge quiz, he was on the winning team. And after that hiatus, he came to UWI. He did his medicine there, and then he went on to pursue internal medicine. Internal medicine is a specialty of medicine, a subspecialty, and it really is a physician who focuses primarily on managing chronic illnesses, diabetes, and so on. And after completing his internal medicine training, he completed his master's in epidemiology at the London School of Hygiene and Tropical Medicine and his PhD in epidemiology at the University of the West Indies. So Professor Ferguson has had a very interesting career. He's focused a lot of his work on hypertension and cardiovascular disease. So he's really an expert in that area. And if you look in his publications, you'll find that he has written about different risk factors, how community, early life, and other factors are related to risk of these chronic illnesses. And then, of course, for those who are sick, every time I'm trying to say, okay, you should see an internist, they say, oh, Dr. Ferguson is my doctor. So he's very popular. So I don't know where you get your next appointment to see him, but you can look him up on the internet if that is your inclination. All right. So with those few words, we are going to have him. We're pleased that he's been here to join us, and we'll just have a conversation as we usually do around heart disease. This is February. It is Heart Month. That's the time that people tend to focus a little bit more on their heart and heart issues. And one of the things that we ask about in our survey are things that people may do to check themselves for heart disease. And we find that sometimes people are not fully aware of some of the tests and what they mean. And so tonight is an opportunity for us to explain it, and also for you to ask any questions that you have around it. So I'm going to start the ball rolling, and I think I've welcomed you, Professor Ferguson.
Thank you very much, Marshall. Certainly glad to be here. Hopefully I can live up to the expectations, but we'll see how it goes.
Yes, well, think of yourself as being a Schools Challenge quiz. With no buzzer to stop you from answering. There are no marks taken for wrong answers. All right, so the first question is fairly straightforward. It's really, when we talk about heart disease, what are we usually asking? When people say heart disease, what do they usually mean, or what are we usually referring to?
All right, so I start probably first by just saying what the heart is and its overall structure, so we understand the concept. So the heart, of course, is really a muscular pump that is located in the center of the chest and plays a vital role in pumping blood around the body. Now, when we talk about the heart has 4 chambers, and we have on the left side and on the right side, there are 2 atria and 2 ventricles. And it's important for us to sort of understand that this is how the heart is structured, because the diseases of the heart will be determined by how these various chambers function. Now, the heart is connected to the body by blood vessels. So the heart really pumps blood through these blood vessels to all parts of the body. The right side of the heart pumps the blood to the lungs so that the blood can receive oxygen. And then the left side of the heart pumps oxygenated blood to the rest of the body to carry out its functions. Now, the heart also is important that it has its own blood supply. And the blood supply of the heart is what is called the coronary arteries. And these vessels are important because a lot of heart disease is related to problems with these blood vessels. So when we think about heart disease, one of the more common types is what is called coronary heart disease or ischemic heart disease. And this is usually due to blockage of blood vessels that supply the heart. And what this does is that if there is obstruction to the blood flow to the heart, then it causes dysfunction. Firstly, persons may develop chest pain, which is the medical term we use is angina, and more severe obstruction will lead to a heart attack. So when we think about heart disease, the one that is probably most critical is this coronary heart disease, which may lead to heart attack. And as we're all aware, heart attacks may result in death and other significant diseases. Now, in addition to coronary heart disease, there's heart failure. And heart failure is where the heart is not able to pump blood adequately to meet the body's needs. So remember at the beginning, we say that the heart is a pump. So if that pump is not able to function and to pump enough blood to the various parts of the body, then heart failure develops. And that is usually manifested by symptoms such as shortness of breath, usually with activity, swelling of the legs. You may have swelling of the entire body. And also persons may develop shortness of breath while they're lying down, as well as shortness of breath as rest. So shortness of breath and swelling of the body would be some of the main symptoms related to heart failure. Now, in addition to the coronary heart disease as heart failure, importantly, we also have what's called heart rhythm disorders. And this is usually where there's an irregularity in the heartbeat. It could be either too fast or too slow. And both of these conditions can result in fainting episodes and can also result in sudden death. Persons, for example, might have heard of even like sports persons who have collapsed on the field and died suddenly, or had a cardiac arrest in terms of that baseball player who was fortunate enough to be resuscitated recently. So those are related to heart rhythm disorders. And so those would be the probably three main areas that I would focus on. Just to mention also that there is hypertensive heart disease when there's enlargement of the heart due to long-standing hypertension, and this may lead to heart failure. And then very importantly, when we think about heart disease, we also think about risk factors for heart disease, because before the heart disease develops, many persons have underlying risk factors. And these risk factors include conditions such as hypertension, diabetes, high cholesterol, and cigarette smoking. Other things such as physical inactivity, obesity, excessive alcohol consumption are also important risk factors for heart disease. So I think that sort of highlights the main things. So remember, coronary heart disease due to impaired blood flow to the heart failure because of poor pumping action of the heart, and then heart rhythm disorders because of irregularities in the heartbeat. And all of these can lead to severe illness as well as death. So I trust that's an okay enough intro, Marshall.
Yes, I think you've covered most of the more common forms of heart disease, especially for our setting now, because I mean, maybe many years ago, there would be challenges with like the valves, the heart valves and so on. But I think we're seeing less of that as we're getting more developed and we're getting more of the heart attack and the heart failure and so on, as you have mentioned. So people sometimes, I mean, I was talking to somebody today and they were talking about a relative who just recently died, and apparently he had been having some symptoms which sounded like angina. He was having pain in his arm, and then when he made some concern, or he told his wife that he was concerned, by the time they got him to the hospital, it was too late. How would somebody know whether they may have a heart problem? I mean, you had mentioned a couple of things that they may see, but what may be some warning signs that there is something wrong with the heart that needs to have some evaluation by a healthcare provider?
Yeah, so in terms of the symptoms, and we probably should note that a lot of the symptoms develop late. So we really would want to be able to prevent heart disease, usually by preventing the risk factors or treating the risk factors. So we'll talk a little bit later on about healthy diet and physical activity and so on. And then, of course, there are many, many persons who have high blood pressure, diabetes, high cholesterol, and it's going to be very critical that those are treated. But in terms of the specific symptoms related to heart disease, first we think about things like shortness of breath and chest pain. So most of us know that if you run suddenly and then overexert yourself, you find yourself breathing very fast, having some difficulty, and that's normal because you have exerted yourself beyond measure. However, some persons may find that with little activity, walking up a flight of stairs, walking up a hill, or doing things that they were able to do before, that they're developing symptoms of shortness of breath. So shortness of breath would be one of the main symptoms to say there's some underlying heart disease. Very important also is chest pain. And I'd want to say not just chest pain, but chest discomfort, because a lot of times patients with with heart disease may describe it not as a pain. So the classic angina is a more or less sudden severe chest pain brought on by activities in the center of the chest, often described as a crushing or tightness in the chest. And many people demonstrate it by clenching their fist to describe what that sensation is like. So that tightness, pressing, discomfort in the chest, usually brought on with activity, would be a strong sign of possible heart disease. However, sometimes the symptoms are much less specific. It may be some discomfort in the pit of the stomach. We call that the epigastrium, and persons often write that off as being stomach discomfort. But if persons are developing these symptoms, it still needs to be evaluated, because sometimes what we write off as indigestion or chest discomfort was actually heart disease. And then at other times, we may have what is called referred pain. So the pain may not be so much in the center of the chest, but it may be referred to the shoulder or to the left arm. Sometimes persons may have pain in the neck and so on. So you can have chest discomfort or pain that may not be typical. And also persons with diabetes tend not to have typical chest pain. So we have to bear that in mind. So shortness of breath, chest discomfort would be two of the major signs. Also important, as we mentioned before, is swelling. So swelling of the legs is a common symptom of heart disease. And just to put some clarification, so leg swelling in terms of major complications may be due to heart disease, may also be due to kidney disease, may be due to liver disease, or sometimes may be due to disorders of the veins. Quite commonly, it is due to disorders in the veins, but we cannot make that definitive statement until we have done an evaluation. So somebody who has leg swelling should see their doctor to have evaluation done to determine whether or not there's any heart disease, kidney disease, liver disease. And if all of those are negative and the other symptoms are suggestive, then we can conclude that this may be due to venous disorders. Additional symptoms include palpitations or racing of the heart. So that's usually due to the various electrical activity abnormalities. So those are important as well. So if persons have episodic racing of the heart or persistent racing of the heart, that would need to be evaluated. Also, persons may have fainting episodes. So particularly when the heart rhythm is slow, persons may actually present with fainting. And usually when persons have fainting spells, we do evaluation to determine whether or not there may be some disorder related to the heart. So those I would put as the main symptoms: shortness of breath, chest pain, leg swelling, palpitations or racing of the heart, fainting episodes would be the more common things to look for as possible signs of heart disease. Other things that we probably would consider including things like coughing and wheezing. So for example, somebody who does not have a history of asthma and find themselves wheezing at nights could actually be due to heart failure. So those are things that one would need to take into consideration as possible symptoms of heart disease.
Mm-hmm. All right, thanks, Professor Ferguson. So those are very important. In fact, I was thinking about it because a lot of Jamaicans, when they are talking about their chest, they refer to it as their stomach. So I like the fact that you're able to show them which part you're talking about. So people sometimes talk about the stomach, sometimes it's the heart. And then just again, the same discussion that we were having about that patient, when he died in hospital, and when they went back, they saw he had a lot of Tums antacid tablets that he had been taking. And so he had apparently been having some angina symptoms, but was thinking that it was indigestion. And so he ignored it. But when he was in trouble, it was a little too late for them to do much at that time. So we've gone through the heart, we've gone through the signs.
There's a question in the chat. Let me just see what that is.
Let me see what it is. Okay, I don't see any question yet, but that's
so the question came directly to me.
Oh, I see.
In terms of whether symptoms are different in women. the symptoms may not always be different in women, but one of the main issues is that because there's a general notion that heart disease is more common in men, then women tend not to be investigators as much. So that also becomes a problem. And again, women may often have make more complaints related to indigestion, stomach disorders, and it is, in essence, people are less likely to attribute chest discomfort or those other symptoms to heart disease, and therefore it often goes undiagnosed. But certainly women do have heart disease quite commonly, especially after menopause. So we should not consider that to be unlikely. And also that within our setting, we do have a very high prevalence of hypertension and diabetes, and these are often more common in women, and therefore it's important that we think about heart disease in women as well.
All right. Okay, so we have those things to also remind us that sometimes when we assume that it's not heart just because of how we look or who we are, we shouldn't take those chances. So it really does point us to having some sorts of tests done to figure out what is going on. And I see these very nicely prepared slides on some of the different heart tests are available. And I'm going to ask Professor Ferguson to talk a little bit about each of these tests, just to maybe explain what they are, because sometimes people do heart tests and they say, well, I had a test for the heart, but they may not be sure exactly what test they did and then what that test might show. So one of the first tests that we're going to talk about is the electrocardiogram. So I don't know if you want to explain for us what the electrocardiogram, sometimes they call it an ECG or an American EKG. What is that about? What is that heart test about?
All right, so yes, the ECG is a very important test, and we're seeing the picture of the normal ECG on the screen. So essentially, as we mentioned at the beginning, that the heart is a pump, and one of the characteristics of the heart is that it has what we call, well, the term they use is automaticity, which means that it spontaneously generates electrical currents. And then these electrical currents are transmitted through the heart and help to stimulate the contraction of the heart, resulting in the heartbeat. Now, what the ECG does is that it picks up these electrical currents from the heart in a typical tracing. And therefore, we can assess the electrical activity of the heart by looking at the ECG. Now, what happens, how this is done, is that electrodes are placed at specific positions on the chest and also on the limbs. And then the machine reads these electrical currents and presents a printout of this electrical current, which is called the electrocardiogram. And this normal electrocardiogram has specific waves and segments, and therefore we can assess whether or not the heart rhythm or the electrical activity of the heart is normal by assessing the extent to which the individual's picture deviates from the normal. So it's a fairly simple test to perform, can be done in just 5 to 10 minutes. Once the device is available and persons are trained, and then you get a printout, and then by reading the printout, we can make certain interpretations. So the things that we can learn from the ECG, first of all, whether or not there's a normal ECG, and we look for specific patterns in what we call waves and segments. And I won't go into the details, but essentially what you're seeing on the screen is what a normal ECG wave would look like. Now, in addition to saying whether or not the ECG is normal, then we can assess whether or not the conduction or the flow of electrical current through the heart is normal. So first of all, is the heart rhythm originating from the correct or the standard place, which we call the sinoatrial node? So it means that you're in sinus rhythm, and therefore you have a normal heart rhythm. Or is it from another site? So that we would be able to say, then we can look at whether or not There are other changes in the heart, such as signs to suggest that the heart is enlarged, by looking at the height of the waves in particular to say whether or not the heart is enlarged. And then we can look at other very important things, such as being able to diagnose a heart attack or impaired blood flow to the heart, because that causes particular specific changes in the ECG, which pretty much all physicians can identify when we have significant abnormalities suggesting of a heart attack. And we are also able to diagnose other heart rhythm abnormalities, such as like atrial fibrillation, where the top chamber of the heart is not contracting properly, and therefore you get, very ineffective waveforms. And that particular pattern is associated with very high risk of stroke, etc. So essentially what we're doing with the ECG is to look at the electrical activity of the heart. We can say if this has a normal rhythm, if the pattern of the ECG is normal. We can say if there's impaired blood flow to the heart or ischemia. We can diagnose a heart attack. We can diagnose heart rhythm disorders with the ECG. Fairly simple test, non-invasive, not very expensive, and widely available in most settings. So a very good test as an initial test for heart function.
Okay, all right, thanks, Professor Ferguson. So if you're having racing of the heart, or if you suspect that you may be having a heart attack, then this is really a useful test. Or sometimes if you're having fainting as well, it's a helpful test to figure out what's going on. All right, the other test I want to talk about is the echocardiogram, which is another, this one, I'm going to leave this one for last. I don't have an echocardiogram picture there, but we can talk about the echocardiogram, which is Professor Ferguson.
All right, right. So the echocardiogram essentially is a special type of ultrasound. So most persons have had ultrasound tests done at various points in times or seen people do ultrasound. And it's a special ultrasound that is geared at the heart. And essentially what is done in the same way as the ultrasound normally is done, there is some gel placed on the chest, a probe is connected, and then pictures of the heart are demonstrated on a screen. So usually it's done in a specialized center where that machine is available. Now, what the ultrasound of the heart does is that it gives us two important bits of information. It can tell us about the structure of the heart, and it can tell us about the pumping function of the heart. So as we spoke about at the beginning, the heart has these 4 chambers, and we didn't say a lot about valves, but controlling the flow of blood through the various chambers of the heart are these important valves. And therefore, the ultrasound or the echocardiogram can be used to assess the size of the heart. Is the heart enlarged, or is it not enlarged? It can assess each chamber separately. So you can say whether or not it's the left ventricle or the right ventricle, the left atrium or the right atrium. You can give a size for each of those chambers and say whether or not that's normal. You can also assess across the flow across the valves to see if the flow is normal or if the flow is abnormal. Are the valves incompetent? Is there backflow? Are the valves narrowed? So you can assess the flow of blood in the heart and the flow of blood out of the heart as well with the echocardiogram. And additionally, you can also assess the pumping action of the heart. So is the heart pumping strong or is the heart pumping weak? And therefore, you can assess how well the heart is pumping. And we usually report something called the ejection fraction, where if your value like is 50 and higher, that's usually okay. If your value is less than 50, 40, 30, 20, then that suggests that there's significant heart disease. So you can assess the pumping action of the heart via the echocardiogram. And then additionally, you can also assess blood flow to the heart by looking at whether all the sections of the heart move equally, or there are some sections that are not moving very well. And we call these wall motion abnormalities. So you may be able to pick up that this segment of heart muscle is not moving very well, and that would suggest that there is obstruction to the flow, or that the person might have had a heart attack in the past, or is having impaired function of that particular segment at that time. So the echocardiogram tells us about the structure, the size, the flow of blood in the heart, as well as the pumping action of the heart. It's a very useful test, and it's now much more widely available than it used to be, not as widely available in the public sector as it should be, but in the private sector, it's fairly widely available, and the cost, while not cheap, is not prohibitive. So an echocardiogram would be a good test to do where there's suspected heart disease.
All right, thanks, Professor Ferguson. And so both of those tests are kind of fairly non-invasive, because usually for them, persons are lying down. If in the ECG, you're putting things on the chest to look at the electrical activity of the heart. With echocardiogram, you're using the gel and looking at the shape of the heart and how it's functioning, how it's pumping, etc. But people have heard about stress tests, and I don't know if you want to talk a little bit about what they mean by stress tests when they're talking about a stress test to check if you have heart disease.
Yeah, so that's also very important. So to put the things in context, we spoke about the ECG and the echocardiogram, but what happens is that some people with heart disease may actually have a normal ECG or a normal echocardiogram when these tests are done under normal circumstances. So as Professor Tully pointed out, usually you have the patient lying on a bed, and they are resting, and while the echocardiogram is being done, and therefore, if the heart is not placed under stress, sometimes things are okay. And as we spoke about the symptoms of heart disease, that persons often develop this chest pain when they're doing activity and they're climbing stairs, walking up a hill, and doing these sort of things. So it means that under normal circumstances, you may get a normal test, but the person still has heart disease. So what the stress test seeks to do is to try to mimic what happens when the person is under stress, and therefore to evaluate the heart during such circumstances. So the first type of test that we can do is the exercise stress test. And we can do this for both the ECG as well as the echocardiogram. The more common one is the ECG. And what is done is that the ECG leads are connected to you as would normally be done in the resting state. But what happens next is that the person is actually now placed on a treadmill and asked to do exercise. So you're exercising on the treadmill while the ECG is being recorded. And what one looks for is to see whether or not some of the changes that suggest underlying heart disease now show up when the person is exercising while doing the ECG. Sometimes a person may also develop chest pain or other symptoms while doing the exercise, and that will help in clarifying the diagnosis. Now, in addition to the stress ECG, we could also do a stress echocardiogram. And the stress echocardiogram is a similar concept. So the echocardiogram is done initially at rest, and then the person is put through an exercise protocol. And then after they have gone through that exercise protocol, the echocardiogram is repeated, and you're seeing whether or not there are changes that are initiated by the exercise. Now, in some situations, persons may not be able to exercise because of limitations. They may have arthritis or other problems that makes walking on a treadmill difficult. And therefore, under those circumstances, we can use medications to simulate what would happen if the person were exercising. So usually these medications are given, they cause the heart rate to speed up, and it sort of mimic the stressful condition. And then with those specific medications being given, the ECG is done or the echocardiogram is done under stress setting. So essentially the stress test is where we are giving somebody either exercise or specific medication to put to really increase the heart rate or put the heart under some stress, and then see whether or not we're able to diagnose an abnormality, whereas if the resting test was normal. And just to add that where there is an abnormal stress test, often we recommend that persons go on to do additional testing, for example, an angiogram, which can further help to diagnose heart conditions.
Okay, so I think I was going to talk about another kind of test, but since you brought up the angiogram, we could probably just talk about that to tell us what is this angiogram that you're talking about. I know people have different ways of describing it, but you can just explain it. What is the angiogram and why would they need it after a stress test?
All right, very good. So we see a picture on the screen, which I think is very helpful. So with the angiogram, what we're trying to do is to actually get a picture of the blood flow to the heart. And but in order to do this, we have to be able to get into those blood vessels. So the way to get into those blood vessels is to pass a catheter, and usually that is done using one of two routes, as shown on the screen here. You can use the vessel in the groin called the femoral vein. And in terms of passing the catheter in, then you track that up to the heart. And then from there, you now get into the heart, you get to the blood vessels that supply the heart. When you get to that level, you inject a dye into the blood vessel, and it gives you a picture of those blood vessels that you can see on a screen in the radiology suite. So this is done under a special X-ray test we call fluoroscopy. So you can actually see the activity. So while the catheter is being passed, you're actually monitoring the movement of this catheter, and then you get to the blood vessel, inject the dye, and you're able now to see a picture of those blood vessels on the surface of the heart. In addition to using the groin, it can also be done from the elbow. Similarly, you pass that catheter into the vein, gets into the heart, and then to the specific vessels. Now, when you get the picture of the blood vessels on the heart, then you can see if there is narrowing. Now, where there is narrowing, then that suggests that that particular vessel is diseased, and it may affect one vessel, or it may affect two vessels. It could affect three vessels, depending on the specific situation. So what the angiogram really does is that it allows us to get a picture of the blood vessels to the heart. And one of the good things about the angiogram is that we can actually intervene to correct the problem at the same time that the angiogram is being done. And this is usually done by passing or a stent that is placed in the blood vessel to keep it open. So if the narrowing of the blood vessel is seen at angiography, then a stent can be placed, and oftentimes this stent will correct the problem and prevent the person going on to develop a heart attack. In some situations, if the number of vessels affected, or sometimes it depends on the severity of the blockage and other conditions that the patient may have, they may actually recommend an alternative procedure, which is called coronary artery bypass grafting. Now, that's a more invasive test because that is really heart surgery, but that would be the alternative. But many persons you can correct the problem at the same time that the angiography is being done by passing stents into the blocked vessel. So it's a very useful procedure and can have major benefits in preventing further heart disease.
Mm-hmm. So you've kind of taken us through a number of different tests that you have, going from simple to more complex. And I think that the question that just came up is very helpful, because somebody says, if my ECG is normal, do I need to go on to do any other tests?
Well, so again, it depends on the clinical picture. So as we pointed out, that sometimes you may have a normal ECG, but there is disease. So one of the things that they teach us in medical school is that you treat the patient and not the result. So if the person comes to you with signs and symptoms suggestive of heart disease, and that baseline ECG is normal, then it does suggest that further testing needs to be done because you may be missing something. So a normal ECG does not exclude heart disease, but it depends on the clinical picture to determine whether or not additional testing will be done. And I guess that's the dependent on the expertise of the physician. So that's important that the physician makes that decision.
And I guess it depends on, because each of the tests have different ways of picking up. They're not all the same. Some will pick up some things easy, but I guess the more invasive ones will pick up heart disease, certain types of heart disease better.
Mm-hmm.
So yeah, so I think so we've got probably simple, and sometimes people just do what is available. I guess that's an important point too, because the ECG is a simple test. People can do it in their office, and a lot of doctors will have ECGs, but I guess if you really want to know if something is going on, the ECG may not be enough, and it really depends on what else is going on. If there's maybe a lot of suspicion, then a normal ECG may not be enough to make somebody feel comfortable that there's nothing more to be done. All right, so this second question is a very specific one. It's really asking about if you have a specific form of heart disease, in this case, a condition where there is a problem with a connection between the chambers of the heart, what they call atrial septal defect. So the chambers are usually separated, but sometimes there can be a connection between the two chambers. The question is, how often should somebody do an ECG in a situation like this? Or is there another test that you think they may also want to do if they have something like that going on?
Yeah, so for that, I don't think there's a standard frequency. So what will happen is that, so the atrial septal defect is actually most times a congenital abnormality, means that somebody is born with this defect. And some persons have more severe disease than others. It does require that the person be followed up by their doctor, preferably be followed by a cardiologist. And usually for persons who are stable with no complications, maybe an annual visit or once per year is good enough. Now, depending on the severity, you may decide how frequently tests would need to be done. So for example, if somebody has a mild defect and no functional impairment, and they've done an echocardiogram that was normal, then clinical assessment may be all that is needed. However, in some situations, a person may be showing signs of disease. There may be progressive disease, and one wants to monitor what's going on. And in that case, actually doing the echocardiogram may be more useful, because you can quantify flow in with the echocardiogram, which you're not able to do with the ECG. So you can assess the degree of flow across the defect and say, is there more flow? Is there less flow? You can assess the different chambers of the heart to see if there are signs of enlargement and so on. So it really is going to depend on the specific person, the symptoms they're showing, and whether or not there seems to be signs of progression. So if there's progression, the frequency of assessment is more would need to be more frequent. Sorry about that.
Yes. All right. I don't know who is on Galaxy 03, but if you can mute your mic, that would help. I'm gonna ask
The host can
somebody else
mute that person
if we
as
can
well.
mute that
So
person.
the host could mute that person, yeah.
Okay, all right. Okay. Okay, all right. So we have more or less gone through a lot of this testing. There's a question here about Cadium mobile device. I don't know much about that device. Professor Ferguson, do you know?
Well, I'll start and probably ask Professor Williams to clarify. So what,
Okay.
I may not be, so there are several devices now that can monitor heart function. So your Apple Watch and other devices can actually report on ECG and report on other things. I think it's interesting. The technology still needs a little bit more development. I'm not quite sure how much validation has been done. But yeah, go ahead, Professor Gus Williams. Let's make sure I'm on the right track.
Hey, good afternoon.
Yeah.
Thank you, Prof. I'm really enjoying the content. It really has been very good and easy to understand. So on Amazon, you can actually buy a device for $99 US. It's actually CardioMobile. I'm sorry, my spelling was incorrect. So you just put your fingers on it, right and left, and it's connected to your phone, and it outputs an ECG. So according to them, it can detect at least 4 different irregularities.
Yeah. So the issue with those again is the whole question of validation. And for persons who are probably less so validation means that we have tested it against a gold standard and we can be confident that what it reports is accurate. So what often happens is that devices are constantly being developed and they are sometimes presented for their interest in terms of, this is exciting, this is nice. And it may be useful, but it may not be diagnostic. So what I would say at this point in time is that they are interesting devices. It is useful and it may point you to something that says you should go to see your doctor. So it can be useful, but I don't think at this point in time it has gotten to the stage where we can rely on these devices to make accurate assessments. So you still have to see your doctor and get the standard evaluation, but there's nothing wrong with curiosity once you don't take it beyond the level of evidence that there is. So the ones that people are more familiar with will be like your Apple Watch and so on. And these will be able to give ECG reporting and various things, but you still have to have these validated. So maybe in 5 years, 2 years, 10 years, it becomes, acceptable as standard. But for now, it is still, there are still levels of uncertainty as to how useful these are in practice.
All right, and then now the other question I see is from, thanks, Dr. Gossa Williams, Prof. Gossa Williams. Other question I see is also from Dr. Rule, and she's asking about which tests are available in the public sector, and then specifically where cardiac caths are done currently.
All right, so the public sector is a challenge. So some centers will have ECG. If we consider the university hospital as part of the public sector, then most of the tests are available at the university hospital. Outside of that, and I will have to I'll have to be corrected. I know some tests are available at KPH. We do have a number of cardiologists at KPH, possibly at Cornwall Regional. in terms of the other hospitals, we tend not to have cardiologists available, and therefore several of the tests may not be available. So there is limited availability in the public sector. For ECG, as I said, several labs and private cardiologist centers have these available. For those persons who are in Kingston, places like the Heart Foundation will have these tests available at reasonable cost, and so on. So it really would mean that persons would have to be referred to one of the larger hospitals or to University Hospital, or these would need to be done in the private sector or in the non-governmental organizations. Now, in terms of cardiac catheterization, now this requires a recommendation from your physician. So and that usually requires that you should be seen by a cardiologist. So I would not suggest that persons walk in and say, you know, I need to have a cardiac cath done, and I can get it done XYZ. You should be evaluated by a cardiologist, because as Professor Tully explained, this is an invasive test. So in essence, what should be done is that initial assessment by your general practitioner or doctor in the public sector, referral to usually either an internal medicine physician or a cardiologist, depending on who is available. So in some centers, some of the public sectors, the medicine outpatient clinic may be where you're seen first, and then from then you're sent on to the cardiologist. So in essence, it's a sort of a sequence. What we do need, though, is a greater level of efficiency. So in the private sector, most of these things can, you know, follow quickly one after the other as required. In the public sector, it may take more time because you have to go from one facility to another.
Right. Okay, so it's just about 8 o'clock, so I'm going to kind of bring winding down or discussion. If you have any questions, there's still time to put them in the chat. We spoke already around symptoms of heart disease. If you're having shortness of breath, chest tightness, or chest pain when you're trying to do anything, if you're having swelling in the legs or racing of the heart, those could be signs that you have heart disease and that you may need to do one of the tests that we spoke about. But supposing you didn't have any of these signs and you're concerned maybe because, you know, you've heard about heart disease, you've heard some things that are happening today, what are some tests that people should think about doing to just know a little bit more about their heart health, especially if they're not having any of the symptoms that suggest something acute is happening or some emergencies developing in relation to the heart?
Yeah, so first thing that I would say is that we recognize that the risk factors can help to guide us. So persons should initially be screened for the risk factors for heart disease, because we don't want to wait until people develop heart disease. And those major risk factors, as we mentioned at the beginning, include hypertension, diabetes, and high cholesterol. So everyone, particularly those persons 40 years and older, or persons who have a family history of heart disease, etc., should undergo screening for hypertension, diabetes, and high cholesterol. And these probably should be done at least on an annual basis. So that's the first thing that persons can do, screen for risk factors. Also, very importantly, we recommend that people should not smoke at all. So the recommended number of cigarettes is 0. And so persons who smoke should stop, and those who don't smoke should not start. Now, if persons drink alcohol, this should be done only in moderation, usually not more than 1 drink per day for women, not more than 2 for men. It's important to follow a healthy diet and to get regular exercise, and also to get a regular checkup with your doctor. Now, when you see your doctor, you can also discuss whether any additional test is needed. So for example, should you do an ECG? So this is going to be determined by your overall risk profile. And some persons will want to do an ECG just to know what their baseline is, and that is fine. So you don't have to have heart disease to do an ECG, but it's also important that we understand the interpretation, because the normal ECG does not mean no heart disease. So, you know, you don't want somebody to say my ECG is normal, I can go and have all the KFC I want, and so on. It's important that we screen for heart disease, screen for the risk factors, follow healthy diet, get regular exercise, regular checkup with our doctors, and then we can do the additional test as required. Tests like the echocardiogram would be more specific, and those would only be done if there is more of a significant suspicion of underlying heart disease. But what I would want persons to at least recognize, everybody needs to screen for risk factors. Hypertension, diabetes, high cholesterol. Everybody should stop smoking, use alcohol only in moderation, always follow a healthy diet, and exercise regularly. And that will go a long way in preventing heart disease.
Yes, and then of course, if you do have any of these conditions, then you should get them treated properly too, because I mean, the high blood pressure, if it's not controlled, can increase the risk of heart disease. The diabetes as well is increasing your risk of heart disease, particularly in women, and high cholesterol is another important factor. And you know, the live participants all get those tests done as part of their assessment. So I'm hoping that some of them will be ready. I see two comments here, which I'll also mention. So I see Dr. Rulas put on his public health hat, and he's again reminding us the importance of education and prevention when it comes to heart disease. And I'm sure we'll continue our discussion around partnership between the LIFE project and the diaspora of, you know, Caribbean persons who are involved in health, in helping to strengthen some of these messages, because I think that's where people may not be aware and could be resulting in some unnecessary losses. I see also another comment from somebody with my namesake who says that when you're walking, her chest hurts and it's bad. That sounds like what Professor Ferguson was talking about the angina. And that is a sign that you could have heart disease. So you should have that checked out, and maybe starting with the ECG, and depending on what else is happening, the doctor may decide that there are other tests that may need to be done. Sometimes when angina is very bad, we can't run you on the treadmill and so on, because you'll drop down on us. So you may have to go from something simple like the ECG straight to the more complicated test, the angiogram, which is what they spoke about. Okay, I see another comment. If you're at risk for heart disease, is a Bayer okay to have on hand, Professor Ferguson, in case of anything, the Bayer aspirin?
Okay, so yes, in terms of if persons are having symptoms that sound like a heart attack, then it's often recommended that you chew an aspirin and on your way to the emergency room. So that is a reasonable intervention. In terms of taking aspirin without the doctor's guidance, it should still be discussed with your doctor. The issue of using aspirin in primary prevention, that's for persons who do not have heart disease, is now being debated a little bit more, and we have to do what we call a risk assessment. So based on your overall profile, we can assess whether the probability or the likelihood that you will have heart disease in the next 10 years or so, and that can help to guide whether or not we think aspirin would be good for you as general prevention. But if somebody is having chest pain that seems like a heart attack, chewing an aspirin would be a good intervention.
All right. And then now the last question that we have for tonight is a question about blood tests. How important are blood tests when it comes to heart disease? So we spoke about the ECG, the echocardiogram, and other things where we didn't talk much about the blood tests, even though we mentioned some of them indirectly.
Yeah, so the first two things that I would emphasize is actually your blood sugar and cholesterol. So as a routine screening, then we recommend persons screen for high cholesterol and for diabetes and to be treated appropriately. Now, the person who actually presents with signs of chest discomfort, then in addition to the ECG, then we will usually do blood tests that can show signs of heart disease or damage to the heart muscle. These are called troponins, and these can be done in the emergency room. In some private practices, they may also be available and can help to determine whether or not chest pain is of heart origin or it is elsewhere. Mm-hmm. So in terms of blood tests, for regular screening, it's usually screening for diabetes and high cholesterol, but for the person who presents with chest pain, then having blood tests done in addition to the ECG can be very useful in making a distinction between heart disease and not heart disease. As with the ECG, a normal blood test does not rule out heart disease, and you have to take the full clinical picture into consideration. But if you see significant elevation of your heart enzymes, that's usually a strong indicator that heart disease is going on. And even if you thought it was stomach problem, that would suggest that you should go on to the emergency room and have more detailed evaluation so that appropriate intervention can be given.
Yes. All right. So I think there's been a lot of a lot of messages here. I think everybody's commenting that they've enjoyed the presentation. It's been very informative. So I'm just going to do a brief summary because we spoke about a lot of things tonight. We spoke about heart disease, some of the symptoms that people may have that might suggest that there's heart disease, like shortness of breath, racing of the heart, swelling, chest pain or chest tightness. Then we went on to talk a little bit about the different tests that could be done, simple tests from just a straight ECG, where you're just going to the doctor's office, to the most invasive one where they put a wire through the groin or through the hand into the heart to look at the vessels of the heart and different things to check out whether you could have any heart disease going on. And then we spoke a lot about things that we can do to prevent, to know whether we could be at risk of heart disease, even if we don't have any symptoms, and the tests that we can do to make sure that we're okay. And then we had a little bit of a discussion about things that we can do to protect our heart, and it gave us a lot of room for thought in terms of making sure that we know our numbers, what our cholesterol and blood sugar are like, and make sure our blood pressure is properly controlled. And then also, what else did you tell? And then also probably making sure that we don't smoke, that we don't drink excessively, and that we make wise choices when it comes to our eating and trying to be physically active all the time. And as the point was taken, because we have cardiologists, but a lot of them, the specialists who deal with the heart, a lot of them are in the main centers, or sometimes they're in the private sector. So it means that there'll be a fee to access that kind of medical assistance. There are going to be some challenges. So the more we can do to prevent ourselves, to identify it early so that we don't end up as an emergency, or to identify the risk factors and deal with them early, the less likely we will be to have to fight for a spot when it comes to some of those special tests and getting some special procedures done. All right, so with those words, I'd like to thank Professor Ferguson and all of you as well for joining us this evening. I see I have a bumper crowd, so as I said, the name seems to pull out a lot of people. And I don't think all of these people went to St. Jago, but I'm sure I find one of them went to Calabar. So I'd like to thank you all for coming out. We have our next presentation again at the end of March. We try to do it on the 4th Thursday, and we're going to stay on. We're going to officially end now to give people a chance to rest, but I see there are a couple of questions, so we'll go on to just answer a couple of those questions before we sign off for tonight. So thanks everyone, and then I'm just going to look at these these questions and we can just talk informally a little bit before we close off. So here's a question that is here. Professor Ferguson, I did an ECG and was told that by the doctor it was like 5 minutes away from a heart attack. What follow-up test should I do?
Yeah, so I think the issue there is that I would have expected that a plan be initiated if the doctor assessed as someone being 5 minutes away from a heart attack. So usually that would mean evaluation by a cardiologist or at least an internal medicine specialist, and then to determine the most appropriate test. So the test could be an echocardiogram or a stress test. So those are usually the next test to be done after an ECG to determine if there is significant heart disease, and then to go on to the next procedure. So, but if that was not previously done, I think a referral to a cardiologist or internal medicine specialist should be the next step, and then to have those tests done. The cost, so remember that in the public sector, we also have the medicine outpatient clinics. So the doctors are supposed to be able to direct people appropriately. Say, for example, you present at the Spanish Town Hospital. So what would happen is that you can be sent from the casualty to the medicine outpatient clinic who can evaluate. And then if the person is thought to have significant heart disease, then those internal medicine specialists at Spanish Town can recommend the echocardiogram, can request the stress test, or can send the person onto a cardiologist. So what happens is that the systems are there.